Ladies and gentlemen, thank you very much for the invitation. It's a great honor to be allowed to present our latest clinical data. My name is Friederich Asmus. I'm Vice President of Clinical Development at ProQR Therapeutics. ProQR Therapeutics is a globally acting biotech company with the headquarters in Europe in Leiden. Next slide show our forward-looking statements. So what is ProQR? ProQR has a clear mission. ProQR is a patient-centric RNA therapeutic platform developing drugs for orphan diseases with well-understood genetic causality. So it is about developing meaningful drugs. It is capitalizing on a uniform platform, which I will talk about and explain to you what RNA therapeutics are. And all of our programs are executed in rare and ultra-rare diseases where there's only a limited number of companies really developing therapies, so the unmet need is here extensive. ProQR has already reached a clinical stage, which means that we have clinical studies ongoing, not only developing drugs before the use in man. And there are 3 programs that are currently active. The one in the front-runner program, the drug is called sepofarsen. It is for Leber congenital amaurosis type 10. This is the most severe form of congenital genetic blindness. This program is in an advanced stage in the registration trial phase. And then last year we started 2 programs in retinitis pigmentosa / Usher syndrome. The QR421A program, which I will extend on over the next 15 or 20 minutes. This is for patients with mutations in exon 13. It's a specific coding sequence of the Usherin gene called USH2A. And then there's another program in early clinical development for autosomal dominant retinitis pigmentosa with a specific and highly frequent mutation in the Neurodoxin gene. ProQR has undergone a specific journey to become a player in the development of for drugs for genetic eye diseases. Company started 8 years ago. The anniversary was celebrated by us on the 8th of May. It was a company initially focusing on another rare disease, which is called cystic fibrosis. But early on, the founding members of the company detected that there's a huge unmet need also in ophthalmic diseases with genetic causes. And so they joined forces with academia and early on also with patient organization to really get a handle and a jump start in getting a preclinical program together. There's also an extensive in-house working force working on establishing the programs. And this allowed that in more or less 3 to 4 years, the company was able to start already the first clinical program in this most severe form of congenital genetic blindness called LCA10. This is a successful program that over this 2 to 3 years now has already reached the registration phase because the first trial showed very promising results. And on top of that, we have moved 2 further programs into a clinical development stage, which I already alluded to on the Usher study and also the Neurodoxins study. And this is not the end of the story, it's more or less the beginning because our pipeline comprises over 25 additional compounds for different mutations. So hopefully this will continue and address also an unmet need in conditions and subconditions where there are even fewer patients than in the normal or orphan disease. The prerequisite for doing so is that ProQR has built a platform for executing on this precision medicine. So it's a shared chemical backbone, the so-called RNA oligonucleotides. They are more or less patching the mutations, the errors in the DNA. and that is a versatile approach. And then we're building on a rather abundant and well-established administration mode. It is called intravitreal delivery, that is done in age-related macular degeneration or diabetic eye disease regularly. So we know about the risks, and we know about how to apply procedures that guarantee optimized safety. And as opposed to other therapies that, like gene therapies, that require more sophisticated surgical procedures from the retinal specialist, this is a drug that distributes readily to affected tissues in the eye. So it also has the opportunity to reach central and peripheral diseases because it's not confined by a certain, for example, injection or a surgical technique under the retina. And last but not least, we have specific models, so-called the optic cup model. These are organoids, so artificial organs built from stem cells, can be raised with patient stem cells that carry the mutation and offer a unique opportunity to test drugs at an early stage and to come up with first dose estimations that then could be moved in the clinic. So some more detail on these retinal organoids. It's important, and this is something that we are advocating a lot, that all our patients get the opportunity to donate or to participate in a skin biopsy program. It's a small skin punch biopsy that can then be expanded and developed into a small eye-like structure, and this can be then used for potentially testing new drugs or even specific drugs for patients in the lab. And this allowed in our frontrunner program, the LCA program, to already quite reliably estimate a dose that is clinically meaningful. So here in the middle, you see a graph. On the left-hand side is the normal control number of copies in the cell, in the cells with which a specific protein can be produced. Untreated in a patient situation, there's almost no copy. And by patching the error in the DNA, this copy number is largely restored. You don't need the full copy number of normal healthy subjects, but have to restore it to a certain extent to see a therapeutic benefit, which we saw already in this LCA trial. And of course, having a dose estimation is a relatively straightforward and quick way into having already in the first clinical trials a meaningful clinical response that you then can build on. Specifically important if the patient number is limited and the condition is ultra rare. Let's look at the mode of action of QR421A. It has a specific molecular mode of action in that it skips mutated sequences, so sequences of the DNA that have a flaw, and in the transcript, this flaw is then removed. So if you look at the left-hand schematic, there is a photoreceptor drawing, and usherin transports important functional proteins through the photoreceptor. This is only guaranteed when the protein has the normal composition, so the normal order, exon 12, 13, and 14, in the coding transcripts, so-called mRNA. In case you have mutations in exon 13, either the protein is shorter, non-functional, or the coding information, the mRNA, is deleted from the cell, so there is a lack of usherin protein, and the protein trafficking in the photoreceptor cannot commence. QR421A here has the effect that it patches the mutation in exon 13. The transcript is then one that lacks exon 13, but still is functional and able to provide a proper support for transport of proteins through the photoreceptor. Building on that optic cup retinoid model, we also were able to estimate a good starting dose, what we know now from the interim results, which is 50 microgram. You see here the schematic that you already start having a response at 1 microgram in that model. That equates roughly 50 microgram. And therefore, the study design of the so-called STELLAR study, the first in human study, also has the 50 microgram dose as a starting dose, and then there are additional dose levels, 100, and the highest dose level that we are currently investigating is 200 microgram. So what is RNA therapy? I briefly touched on it already. I touched on the individual route of administration, that this is an established route of administration that can be done by essentially every retinal specialist. The administration itself is not different from other drugs that are frequently given for other diseases. The injection, however, is luckily less frequent, so 2 to 3 injections per year may be sufficient to have a continued effect. And there is no additional chemistry than the molecule itself, so there's no viral vector. There's nothing in addition. It's just a naked molecule, that RNA molecule that exerts the effect. Also, as this is not a complex surgical procedure, the drug is distributed through the eye to essentially all tissues, and therefore affords for a broad ability to target certain tissues, not only in the center, but also in the periphery. And you all know that in Usher's and retinitis pigmentosa, much of the disease progression happens not in the center, but also in the periphery. So broad distribution may be favorable specifically for these diseases. What is the key of the evolution of the symptoms that Usher and retinitis pigmentosa patients have? You all very well know that. This is just for recapitulation. It starts in childhood with night blindness, then the visual field loss progresses, and finally also central vision, so reading vision is impacted and gone, and in the worst case, patient even progress to light perception only. How can that be measured in a clinic? So there are 2 ways of looking at it with certain assessment techniques. One is visual field. So how broad is the visual field? And the other is visual acuity, which is a central foveal vision, so center of the retina function. And this, there are also standard ways of measuring visual acuity. For the visual field, we have in our trials currently 3 different modalities. Microperimetry looks more in the center. Automated perimetry looks for the breadth of the visual field. And there's a specific form looking at rod function at visual field at low light levels that is called the dark adapted chromatic perimetry. And in the schematic, you see that in different disease stages, the visual field gets narrower and narrower. And of course, the ambition is to slow that process or hold or even slightly reverse it. And then there's a functional test on light sensitivity of the retina called the Fullfield stimulus threshold test. It's applied to all patients in the STELLAR trial. It's capturing the performance of the most sensitive part of the retina. And this test showed a directional improvement in the treatment group and can be taken as an indicator of increased light sensitivity. In addition, we are also interested in structure of the retina and of the photoreceptors, because Usher syndrome and retinitis pigmentosa are degenerative diseases, so there is loss of retinal structure ongoing, and this can be captured with optical coherence tomography. The degeneration of photoreceptor cells can be measured with a specific parameter called the ellipsoid zone. You see that on the right-hand side in lilac. The photoreceptor layer is called the outer nuclear layer, and these measures allow a reliable delineation of the extent of photoreceptors and their loss over time. the therapy would here slow or halt the progression of deterioration. So what is the trial design like on the STELLAR trial and the Usher trial? The objective was to really establish early safety and tolerability and characterize early examples of functional target engagement. Means, of course, for a first trial, you don't claim to have the exact dose and the dosing interval, but you want to see if the doses and the way you administer the drug has the potential to yield meaningful improvement and has the potential to be moved to further clinical studies. This is how the so-called STELLAR trial looks. It has 4 dose cohorts, as we alluded to briefly, 50, 100, and 200 microgram. The first cohort comprised 4 active lead-treated patients, and as a control, 4 patients in whom it was pretended that they received the treatment, so-called sham procedure patients. Then the dose was escalated after the safety of the 50 microgram dose was demonstrated to 100. And then an interim analysis was performed to see where we stand in respect to safety and also therapeutic effects. And currently, a little bit delayed by the COVID pandemic, we are including patients in cohort 2B and 3 to hopefully finish the trial then in a couple of years from now with the last patients, and to have all further readouts end of this year on the higher doses and longer follow-up of the previous dose cohorts. So this is the trial population as it entered the interim analysis. There are 4 patients on 50 microgram, 4 patients on 100 microgram, 6 patients received the sham control treatment, so no active treatment. It's important to know that all of us have 2 copies of a gene. If you have mutations in Usher, you need to have 2 mutations to get the disease. In this specific case, we looked specifically at mutations in exon 13. So some of the patients had 2 mutations in exon 13. They are called here homozygous. And for example, in the 50 microgram group, there were 3 patients with mutations in each of the exon 13 alleles they had, and 1 heterozygous. So this patient had another mutation in another spot of the gene. Phenotype varied, so it was rather balanced, that at least in the actively treated group, 50% had an Usher presentation with hearing impairment, and 50% didn't have hearing impairment. And also the visual acuity and visual function level was more or less similarly distributed, with 2 mild to moderate in the 50 microgram group and 3 in the 100 microgram group. And the follow-up, of course, varied, as the trigger for the interim analysis was at least 3 months in the 100 microgram group. Those had 3 to 4 months follow-up, and the 50 microgram had almost up to 1 year follow-up. So how do the results look like? So we looked at altogether over 1,350 subject treatment days in the IAs. There were no serious ocular or non-ocular adverse events. There was no evidence of inflammation and no treatment associated cataract. So that can be one of the adverse events that are of interest if after treatment the lenses become opaque, blurry, and need replacement, but that was not observed. There can be also toxic effects at very high doses to the retina, called cystoid macular edema or retinal thinning, and also this was not observed. This is the core slide. So how did on top of the beneficial safety, the favorable safety, how did the efficacy look like? So 25% of treated subjects were defined or could be categorized as responders, and they were called responder 1 and responder 2. And I want to guide you through the profiles. Responder 1 had a moderate visual impairment of roughly 70 letters, had 2 mutations in the exon 13 of the H2 gene, and only received a 50 microgram dose and was followed up for 9 months. This patient showed a good therapeutic response on the retinal structure as measured in the ellipsoid zone decline, showed improvement in the visual field and in the retinal light sensitivity. There was no change in the BCVA. BCVA was stable. And responder 2 was much more advanced, had in the treatment eye only 30 letters visual acuity, so quite progressed, had only 1 exon 13 mutation and received 100 microgram, was followed up for 4 months. Here we did not see an OCT retinal structural response, probably because the subject was too advanced in the structural degeneration. Still saw an improvement in the visual field and in the retinal light sensitivity, and also saw an improvement by 6 to 7 letters from baseline for the visual acuity. So also here, highly meaningful effects. And these are summarized here in graphs. So the effects that I explained to you on the left-hand side, the retinal light sensitivity, the white bar is the treated eye. Remember, everybody received only 1 injection. There was stability of that light sensitivity in the treated eye, whereas the light sensitivity in the untreated eye declined, and this is the upward curve. So stability in the treated and decline in the untreated eye. For the retinal structure is the other way around, that the EZ, and that is the white curve, is essentially stable or even slightly improved in the treated eye in white, and the lilac curve shows a slight but steady decline over time, over this up to 9 months follow-up. For the visual field under low luminance condition, we see here a meaningful improvement over the first 12 to 16 weeks, and then a decline, whereas the contralateral eye, the untreated eye, does not seem to change a lot. Overall, specifically in the visual field, we already see that there may be a dosing interval at this dose level of something like 4 to 5 months realistically estimated. For responder 2, here similar picture. So downward slope for the retinal light sensitivity means improvement, whereas the lilac showed a slight dip, but then stabilization. So overall, improvement of light sensing in the treated eye with largely stability in the contralateral eye. The retinal structure, as measured by the EZ, improved in the treatment eye in white in the middle graph, and was stable in the contralateral eye. And for the visual field, a similar response in the visual field for the treated eye as opposed to the untreated eye. So to sum up the efficacy and share some of our thoughts on the adaptation of the trial while it's ongoing, 2 out of 8 421A treated subjects demonstrated therapeutic benefit. None of the 6 sham-treated subjects met the responder criterion. There's early evidence of efficacy at the lower of the 2 dose levels tested, and this provides further validation of the ProQR platform technology. The early responder data also provide guidance on further adaptation. One logic element is to now look at patients that have 2 exon 13 mutations, so-called homozygous, treat them also with the 100 microgram dose and see if there is an even stronger effect because they have the double a copy number of mutated alleles that could be subject to the patching by the drug. And also it is of interest to see what happens at the double dose of 200 microgram. So what did we achieve and what is next? So far, there is early demonstration of early safety and tolerability. We have seen examples of functional target engagement and benefit, and this is also informing about the dosing interval to be 4 to 5 months potentially. We have assessed the utility of various outcome measures. I've shown you the various perimetries here in moderate and advanced disease, and have now a much better handle on how to apply them in forthcoming trials. Also about the technical optimization of the protocols and how we look at them. Further dose ranging is underway, and also looking at effects if you have 2 mutations in exon 13. And what we still have to really characterize and manage in the next trial is really the exact contribution of the drug dose and the gene dose, so having 1 or 2 alleles, and of course the durability of the response in those patients that have showed already some benefit and target engagement in the STELLAR trial. Thank you very much for your attention.